So the mother and baby unit, everything will revolve around this principle. And this principle is so important that mother and baby unit should never be broken unless there is a major reason. Small organizational reason like, oh, I'm not used to it, or I don't have staff for that. Should not be an excuse, really. So this is going to around this. And the basic principle is that mother and babies are one. This is a unity of mother and baby. And of course, during pregnancy, it's obvious to understand that mother and babies are one because, you know, baby is inside and is bathing into hormones and everything in the feelings of the mother. But now with research, we understand that they're one for even longer after birth. They're still one. And breaking this unit is not without risk, okay? Let's say, for example, I'll give you the best example of that is the American Society of Pediatrics. About a couple of years ago, they came with a recommendation that babies, newborns, should sleep in the mother's and the parents' room for at least a year because it decreased the rate of SID, you know, sudden infant death syndrome, by half, 50%. So why is it? You can ask, you know, why does it make a difference where the baby sleeps? It's because there is a relationship, there is still a link between, it's a mysterious one, but it's there. Because if you break it, it's not without consequence. You can have the other consequence. So you see all these little things that we used to say, oh, well, before we had enough research and statistic, we did not understand that possibility. So, okay. So baby, mother and baby are one. Okay, let's use a little arrow then. Okay, mother and baby, they are actually, I call it thinking for two. The mother is thinking for the baby, and for a long time after birth, actually. These are hormones, you know, oxytocin, prolactin, endorphin. I'm not going to spend too much time on this because you probably know about these hormones and the way the value of the equilibrium of these hormones for delivery and labor and delivery and successful breastfeeding and so on. But our role is to make sure that we don't disturb that too much, okay? Cortisol is also a very important hormone that will compete with the other one. If we increase the cortisol level too much, it's going to disturb the rest of the equilibrium. Let's go then, you see that these new research, they has, as you know, because of all these new discovery and their realization that the effect of this mother and baby unit is so important, the Royal College of Physicians and Surgeons of Canada came up with a policy statement in 2014. It says, you know, that's a quote from it. Adult health is more influenced by events and condition in early childhood and even before birth than was ever imagined in the not too long distant past. Check the other one. Experience in early life become biologically embedded. Get under the skin. That's an expression that they use in research now a few times. I saw in research article. Get under the skin, meaning they really embed. And it changed the way that certain genes are expressed. So the expression of genes like this, we call that epigenetic. Anyway, I'll get to that a little later. All of this, what I'm going to be speaking to you for the next maybe 15, 20 minutes, is it comes from DOHAD, Developmental Origin of Health and Disease. This is a new area of research, and if you Google this, you will see the University, Cambridge University in the US. Many people are just homing that to do a lot and publish a lot of research about the possibility that the disease that you have, let's say high cholesterol or high blood pressure or cardiac disease or anything like that when you're 50, 60 years old, comes from something that happened very early there, you know, around the pregnancy and birth. We say that these functions are programmed very early, even before birth, depending on the environment and the experience. So the experience that we get our newborns through will be very, very important, okay? So that's one thing. You see, in the mechanic of this, there are two mechanisms to explain this DOHAD, developmental origin of health and disease. One is epigenetic, mostly epigenetic, I would say. It refers, I'm just going to define it a little bit. It's referred to any process that will alter the gene expression without changing the DNA sequences. It means that the DNA you inherit from your father and mother, and it's well known that it's forever the same, except that there are some proteins that can fix on the DNA molecule, and then they act like dimmer switch. They can either increase the expression of a gene or shut it down. Okay, so this depends on the experience that you have. Okay, so this epigenetic will alter DNA mechanism. It will, and then through brain plasticity. Brain plasticity is the capacity of the brain to modify its structure. So it modifies itself. And there is something you should know right at the beginning. The newborn, human newborn is the less developed newborn in the mammalian world, in the world. You see, it's going to take 9 months to a year for a human newborn to reach the level of development that any other mammal has right at birth. They can walk, they can swim, they can do all of these things, but humans, you know, it's very long. That's actually a window of opportunity, because it means it's like, if you say it 9 months before the baby can walk. So it's like another pregnancy, another 9 months that you can interact with the development of the brain, so that you can either mitigate or reverse the effect of stress or other phenomenon that earlier happened. So this is our window of opportunity, and this is very important at birth that you set it properly. We'll see it later. Just to give you an idea, a newborn, for the first 3 years of life, they develop 700 new connections in the brain every second. So it means that anything you say, any experience they have, anything they do, they record it. It just make structure the whole brain for the future. And there is this principle here I want you to understand. When exposed to stress, a fetus or newborn will favor survival over development. And we're going to be using this, you know, for the next also half an hour. You can either go survival or you can go development. I'll give you an example of that. If you have the mother is smoking, and she's, of course, you know, the baby has less oxygen and all these toxins and everything. And so it creates a stress on the placental circulation and so on. So the baby will be smaller, okay? And then you realize by ultrasound that the growth is retarded, the intrauterine growth retardation, IUGR, something like this. And then the team decided we should deliver this baby because it's small, and it's small for gestational age. It's not premature, but it's just small for the age. So you decide to deliver this baby. So you call the peds in and everything, and everybody will say, okay, let's get ready for NRP, you know, because this baby is small. But guess what? By experience, you know that these small baby, they rarely need NRP. They're vigorous at birth. They're small, but they're vigorous. Why? They favor survival. Knowing that they were lacking something, they favor survival. So they're usually very active at birth. They don't need much help, but they're small. They didn't have so much development. They favor survival over development. That's the whole story of the reaction of a fetus to stress. They favor survival. Okay, so let's go there and see this. We're further into how it works. You know, that for the last 20 years, even more than that, almost 30 years, there was lots of research about what is this programming all about. And this programming, it has, you know, make it short, it has everything to do with cortisol. If you overexpose the fetus to cortisol, then it will have an activated HPA axis. HPA is hypothalamus pituitary adrenal axis. It means basically, for those who are not familiar with HPA, is it's the cortisol manufacturer kind of. You know, if you activate it too much, it will have an adverse metabolic profile and behavior phenotype in adulthood. It's programmed like this. And I want to add another detail, technical detail, is that this is happening at the level of the hippocampus. Hippocampus is this part of the brain that drives the HPA axis. So if the hippocampus is very nervous, very full of fear and everything, then cortisol will be produced. So hippocampus development is very important. And the whole thing about these programming system is cortisol, okay? I'll give you an example of that, just to tell you what is the effect of programming the hippocampus early in life, even in the prenatal phase, okay? The best, you know, that's a very good example because it's a long-term follow-up. It's the Project Ice Storm. Maybe some of you remember 1998 in Quebec and in Western Quebec and Eastern Ontario got stuck into a very huge ice storm, and people were without electricity for some time, weeks and months. So that was kind of a small natural disaster. And when we're thinking about COVID today, I mean, this is something similar. So let's check what happened. There was this nice study. Dr. Susan King, she's at the psychiatry department at McGill University, and what she did, and she collected 85 patients that were involved during pregnant. They were pregnant during this ice storm, and 85 patients involved in the ice storm, and compared to 85 other expecting mother that were not involved. They were all in the same, somewhere else in the province that was not involved with the ice storm. Results, she published in 2008. The kids were 5.5 years old, and guess what she found? Lower cognitive IQ, 10 points different of IQ between the two groups. And language abilities were less, and so on and so forth. So that was one of the first time they really were following prospectively a sample of population like this. But then see the rest. She published again when they were 15 years old, and guess what? Dietary problem, emotional problem, aggressiveness, drug use. They were adolescent now, and the loss of 10 points of IQ was still there for boys. Girls had recovered. Well, that's a nice news for girls, huh? They're more resilient or something like this, but that's another topic we could discuss differently. But you see, that was a surprise also. And what they did is epigenetic DNA study of these kids. And what they found is epigenetic changes, like I explained at the beginning. DNA methylation were still present in about 950 genes. And they say briefly that it's a global effect on the genome. It's like going to be forever. Well, they didn't know how long it would be. So let's go any further. When they were 20 years old, she was Dr. Susan King was interviewed by a journalist, a reporter, and she said, you know, after even 3-4 years down the road, there were still some autism traits. They were the kids had difficulty in making friends, clumsiness. They had very specific interest, and also as people were getting older, she saw a relation with increased weight, overweight, proportional to the number of days without electricity and everything. You see, even obesity can be triggered by. So what it means is that these kids somehow they went into survival mode, and it's a trajectory that is very difficult to change after that. And the bottom experience is very nice, because when she was asked, she said, I thought that the effect of difficulties experienced by the mother during pregnancy would fade around 5 to 6 years, but on the contrary, it increased with age. So some of these experiences very early in life seem to have a lifelong capacity of disturbing, okay? So that's kind of freaky in a way, but don't freak too much, because there are solutions to this. And that's gonna be our role. Now our role as healthcare professional in these very early days of during pregnancy, childbirth, and early postpartum will be very important, because we probably can change or drive the trajectory. She didn't know back then, Dr. King, but there are some more studies I'll show you. You see, what is the situation today? I just found this research just when I was preparing. I must say that I did present these research at the Society of Obstetricians and Gynecologists meeting years ago, and I'm just updating it now. So this is a very recent research. Was published in January 2020, and this group of brain imaging radiologists, they were wanting to see the evolution of brain development of fetus into the mother. So they recruit 119 very low risk women, because they want to know the normal, very low risk women, no physical, mental illness. These women were describing themselves as doing very well and, you know, successful and so on and so forth. So to make sure that their group was homogeneous, they did some psychological testing on them. Big surprise. 64% of these women tested positive with standardized psychological tests, pen and paper tests that you fill, and they're used very commonly. I wouldn't be able to name them, but they're very standardized, known and approved in psychology. So 4% of them tested positive for stress, anxiety, depression, or a combination of that. Some of them had both. So that was a big surprise, because they said, oh my, you know, they didn't expect these very low risk. This is a normal, happy Mrs. Smith patient that you wouldn't expect any problem. You get her through the test, you have this. And what's worse is that now, after they collected all the data, these stressed out babies it was associated with smaller hippocampus. Remember, the hippocampus is the one driving the whole thing, the whole cortisol, accelerated cortisol folding, and impaired brain biochemistry. I save you all the details, but it was a huge difference, very significant difference between the stressed mother and the non-stressed. A bit like I just showed you about the ice storm, and it was an ice storm here. What was it? The only thing I could find for these ladies, these patients, most of them, 85% of them, were working mother. But that's about it. There was nothing, and they were from the US. That's another, I don't think it should make such a big difference, but anyway, and these women were recruited in 2018, 2019. It was much before COVID, so there was no effect of COVID in there. But anyway, something is wrong in the population, in our mothers, And all psychologists will tell you they have an epidemic of stress and everything. And so we have to deal with this because it's kind of the new normal, okay? So then why do you think it's so now? Because parental stress is contagious. That's another thing. Over the past 15 years, the number of students with learning or behavior problem all across Canada have increased by at least 72%. We have this epidemic of learning and behavior problem with the youth. And also, you know, there was another article, a pediatric specialist in the emergency room was saying that, you know, in a big, large city hospital, they have 3 suicidal attempts per day by children less than 14 years old. So this is something that we never had before. So I just want to summarize. There is an epidemic of survival mode in the population, and it's becoming a big you know, health problem for everyone. Public health, I should say. Okay, another thing. Okay, that's my last bad news. You know, we're gonna get to the good news. I know I'm delivering you bad news now, but that's the way we should understand the situation now. We have to know what's happening. Also, there is this big amount of research about microbiota. I'll just summarize it in one research. This is a research that was done, I think, if I remember well, from Alberta. And what they did is they checked the microbiota in different mode of delivery, like vaginal delivery, cesarean section, and receiving antibiotics. And I'm just going to summarize it. Only infants delivered vaginally, breastfed, and not receive antibiotic had a normal microbiota. The rest was all disturbed microbiota. But check that one. The greatest deviation was observed after cessation of breastfeeding less than 3 months. If you had 3 months of breastfeeding, things weren't so bad, you know, even if you had antibiotics so now we're seeing things, that small thing that we can do, helping our mother breastfeed, that could have a big impact on different changes that, you know, at least not make it worse. And the clinical relevance of these changes that they say is the microbiota. It's all associated with food allergy, asthma, and atopic dermatitis. So talking of epidemic, okay, epidemic of stress, epidemic of allergy, because now, you know, these kids are all going around with the EpiPen injectors in their bag, and the parents are so afraid that they'll eat something at school, and the school now forbid the peanuts and all of these things. And if you remember our days, you know, that wasn't like that. So now it's things have changed, and probably the reason is that it's all contagious in the family, transfer, you know, and if I had to summarize it in a bad way, we're like creating weaker and weaker generations because we're not providing our mother with possibilities of overcoming these, you know, outside situation and everything. And I can hear you thinking that, well, what can I do with the woman? You know, she comes to the delivery room. I have no power on what she did before, how stressed out she is. She had problem with her partner or something like this. But there is something very important we can do right there to change this trajectory, kind of. And I'll just explain to you now, show you how bad it is and what is the global effect of that. Okay, so this is here from Dr. Bruce Lanphier. He's a pediatric epidemiologist from, I think, Toronto, and he's specialized into environmental toxins. You see, because kids, you know, they're exposed. They're much more prone than adults to be influenced by environmental toxin. I'll make the story short. He says, the worst case scenario, all the kids are so much involved with environmental toxins that they could lose 5 points of IQ. This is the distribution of normal distribution of IQ in the United States. As you know, you have most of us, we're in the hundreds or something, and then on the right side you have more than 130, and on the left side you have less than 70 or something like this. But that's majority is in the middle. So then you could say, what's wrong with losing 5 points of IQ? Look, you have 6 million kids on the right side that are gifted and 6 million that are challenged because they're below 70, okay? Now, what happened if everybody lose 5 points of IQ? Now we end up with 2.4 million gifted, and now we have 9.4 million challenge, okay? Now, let's say we now know that breastfeeding will give every child about an average of 4 points of IQ later on in life advantage, okay? Let's say we don't care about that and we say, okay, let's give a supplement or something and just don't bother too much because it's not so important. 4 points, what's wrong with 4 points? If you're 120, you'd be still okay. But let's do it. If you apply that to the whole population, then you end up with 0 gifted and 11 million challenges because you shift the curve to the left, okay? So, and this situation is about where we're at now. The new normal is that we have very few gifted and we have lots of problems in schools and supporting these kids and everything. And if you speak to an educator, they all agree on that. And statistics showed it very, very carefully. So that's the epidemic, okay? Now, solution, okay? Here's the good news. Bad news are finished. We're going to get into, we still have time for the good news. There are some simple ways to prevent, diminish, or reverse the deleterious effect of stress and promote optimal brain development. And I put that under one header, one title: protect the mother and baby unit. Don't go into, it's not like about this or this or this, but if you protect mother and baby unit, you get the whole benefit, okay? So how do we do this? Delay cord clamping. The first one, let's say baby is just born. We're going to go from birth, to the rest of the time. Delay cord clamping. I'll show you some evidence of that. Skin-to-skin contact at birth. Now we're going to spend some time later in the presentation about OR, because it is the big challenge. I've been around so many hospitals. I know what it is. Skin to skin is usually going not bad in the delivery room, but in the OR it's a big challenge. Okay, so we all want to get that fixed. So that's going to be that's why I write an OR as well. Breastfeeding is very important, of course, for the other reasons I'll explain. And then we have also what we call the quiet time. Keep going, keep giving skin-to-skin breastfeeding and promote tactile stimulation between the mother and the baby. And I'll show you why. And baby carrier, portage, or just carrying the baby in these carrier, and maternal proximity. Favor maternal proximity. This is like I told you about the American Association of Pediatric Association that keep the baby close, at night, things like this. Okay, so let's go now. I'll just quickly give you some interesting research just to give you an example how it works. Delay cord clamping. We've been known for many years that it's super important for premature baby. But now the Swedish people, that in Sweden, they did this study of randomized controlled trial, 400 low-risk infant. And what they found is that skin-to-skin, not skin-to-skin, but delay cord clamping result in improved motor skill and social behavior at age 4. So that's age 4. It's long time after you've done this. And I have to say, you know, that myself, I've been in practice for almost, well, I won't say how many years, but 30, 35 years, but I used to cut the clamp immediately, less than 10 seconds. I did not know that. But now that we know this, we cannot, you know, keep doing our bad habits of, so that has to be done. Anyway, so that's an example here, my first example of something very small, 30 seconds, a minute more at birth. Be patient, just wait, don't do it. And it's going to have a big impact on the development of this kid, okay? So that's one thing. Another example, breastfeeding in itself, because people are wondering, you know, does it really have an impact long term? I know most of you listening to me, maybe you know already, but some people in the operating room don't know that because they're not familiar with all the research. But there are 3 or 4 good, very good research, long-term research about breastfeeding, and I'm just quoting one here. The adults were now 30 years old and they were breastfed or not breastfed or just partially or so on and so forth. So the conclusion is 4 points of IQ. These are the 4 points I showed you earlier. And education, 1 year more of education. And guess that one was surprising. They had 30% more income. So that's the first time that we actually link, but not the first. There's a few studies like this, and you will tell me that there are lots of confounding factors and that it's very difficult to conclude that it's due to breastfeeding and not something else. But these studies were very good at removing confounding factor, and they had a very homogeneous population so that you're sure that, you know, anyway, so I won't go into the detail, but it means that you promote breastfeeding now for a kid, you guarantee a better outcome. Who would have said that years ago? I mean, it's kind of mind-boggling. But I mean, this is our role. This is what we're doing, make a difference. Okay, so that's about breastfeeding. Another one about breastfeeding, I like it, this one. It's about the C-reactive protein. C-reactive protein is a biomarker of inflammation, and it's if it's higher up, it increases your risk of cardiovascular and metabolic disease, okay? So they have this huge population of 15,000 subjects between age of 24 and 32, and what they found is that C-reactive protein concentration in adult was reduced by 20% for breastfeeding 3 months, 26% 6 months, 29% 12 months. Anyway, 20% reduction of C-reactive protein will reduce your cardiovascular risk a lot, you know, later in life. Just to give you an example, the Lipidor, you know, these cholesterol pills that probably some of you take, they gave us this because it reduced the C-reactive protein by 15%. So that's the effect of Lipidor, 15% reduction of C-reactive protein. Now, if you breastfeed, if your mother breastfed you, it gives you a lifetime free Lipidor, you know, more than that, 20% reduction of C-reactive protein. So again, something small that we do with lasting effect, lifetime. So the value of our care now is becoming so important that we should actually ask for a raise of a salary or something like this. But this is the reason why actually the college, the Royal College did this paper, this policy paper. They were asking for more funds, you know, not in school, but it should be funded very early in life, like what we do in the hospital and things like this, because some people say, okay, we're going to open 4 years old schools, you know, the preschools or stuff like this. And they say because it's very important, because it's time to act. I'm sorry, it's probably too late. It's done, you know. It's all the money should come to us. Actually, that's one of the way to think about this. This is it. So anyway, now I'm going into this new science of touch. You see, this was published years ago, but you see the newborn has two of his, the touch and the senses, the touch and the smell are very well developed. The rest is not too, you know, needs some fixing in the future, but the touch is very sensitive. And apparently they bind with the people they touch, and they do all of these, and also many of the research now are showing that you see these 700 new connections they do in their brain. Every second, they are triggered by the touch. And I'll show you the research, some of it. You see, this is, I'm showing you just one, just to so that you understand what I mean. This guy is also from BC. They did a study on pregnant newborn. They sent a questionnaire to a lot of mothers at 3 weeks and 3 months of age. And in the questionnaire, it was a tricky, sneaky questionnaire. They were trying to see the amount of time the baby was taken. And so anyway, so they could separate the population into the babies that were carried more and the baby that they were carried less by this questionnaire. Children who had received less physical contact had a molecular profile indicating the possibility that they were biologically late. The difference in between the two groups were in the DNA sites of the immune system and metabolism. And the surprise is that this is on the site of the DNA exactly the same as the stressed out ladies I show you, and the epigenetic change of the iStorm project. So it means now there is a possibility, and now people are starting to, they call it epigenetic resilience, that it's probably possible during the first few months or first couple of years of life to change the trajectory if you do the proper intervention. Okay, so that's our job. So why is what is the mechanic for tactile stimulation? Some research is still going on about this, but apparently it creates, when you touch, when you massage or touch, it creates the production of a growth factor like FGF2, like it's called fibroblastic growth factor. It has a synaptic repair on the rats. You know, they've shown it very well, that it has a repair mechanism of epigenetic effect on the immature brain. And if you're an adult, it's anxiolytic and antidepressant. If it's the mother that you massage, then it's anxiolytic, antidepressant. If it's the baby, it's repairing the brain, actually. And it's very well shown for in animals that if you prevent the mother, let's say, for example, little mouse or rats, if you prevent the mother from licking the baby is completely lost, you know, development is impaired, intelligence is not good, and it's really bad. I mean, because it's the attention that the mother gives and the actually physical touch. You know, love is not like, oh, I love you, I give you a kiss. No, it's more like touch. Okay, so that's exactly this. So this is the mechanic, just to explain. Okay, on that basis, this is the skin-to-skin Cochrane review in 2014 for this Cochrane review. As for people who are not aware, this is this very highly recognized organization that does meta-analysis and set the standard on many things. The possibility exists that postnatal separation is stressful and result in harmful effect that persist across the lifespan. So I'm not the only one saying this. So these guys, they always were looking at this. And it kept saying this possibility need careful evaluation using the allostatic theoretical framework, meaning that allostatic is the accumulation of stress because of cortisol, and epigenetic, I told you already. So that's the recommendation. Now, how do we actualize this recommendation? something before. We should understand, and that's not a new, that was published in 1929. They recorded the cry of babies at birth, different randomized control trial, different situation. I'm not going to give you all the detail, but the conclusion of the study was human infant, they recognize separation and they cry, they start to cry in pulses. It's not the usual cries of cry of a newborn. It's pulsating. And the crying will stop immediately, almost immediately at reunion. And check this one. This is the human counterpart of the separation distress call of mammalian because it is to ensure survival. If you take a little baby mouse, and then you separate, it's going to start crying immediately. Call the mother, okay? So that the mother comes and take me back, you know, so that I'm near with you so that you can protect me. It's a kind of a predator reflex that if I'm away from mother, I'm going to be eaten by a predator, okay? And this cry, it's very important to understand, it's not dependent on social experience since the newborn has no social experience. It is a genetically encoded reaction to separation. So now I'm going to have you, we're going to together listen to this special cry that the baby have. You will see it's in operating room. The baby is on a warming table, and it's being measured. I know you don't do that anymore probably, but anyway, that's a good example. And then listen to it, and then we'll see after. I'm just going to play this now, like this way. 1, 2, 3, 4, 5, 1, 2, 3, 4, 5, 10, 1, 2, 3, Okay, so did you think the baby was happy there? And I can tell you, I have heard this cry for decades behind me while I was doing cesarean section. We did not know. Now I can't stand it. It cannot be done anymore. Because you see, we don't know if this baby is not already in survival mode. You don't know. Remember my study about the Americans, you know, they're 64% are probably in survival mode. And then what you do, and you send it even more into survival because this baby is totally scared that he's going to be eaten up by an eagle or something like this. This is genetically encoded. And guess what? We used to say, oh, this is good breathing. They have good lungs. I don't know if you heard, but that's what she said. And you could hear the nurse counting the sponges at the back. But it's not, you know, we should not do this. And you see, if you say, oh, send the baby to the nursery because then it's gonna be quiet. What happened to the baby? And this is another reflex I want to stress. After the cry, the distress cry, there will be silence. And the mammalian, that's what they do. If you take the little mouse and you take her away, first, she's going to cry. Then eventually, when nobody picks her up, she's going to duck down into silence because if she keeps crying, the eagle will come. Okay? So if you think the babies are fine at the nursery in their cot, just silent, they probably have a cortisol up in the roof, you know, because they're just now, I'm going to shut up. And then if you're a good nurse and you start manipulating this baby, what will he think? That you're the A girl, something like this. So anyway, and then if you watch properly their behavior, you will see that. So there is only one person that can really take care of this kid is the mother. There's no other way. You might say, oh, the father. Studies have shown that it's going to be better with the father, but this baby will cry a lot more with the father than it would do with the mother. So, but they finally get calm, but you wonder, if they're really calm or they're just so afraid that they're ducking down now because it's a protective thing. Okay, so let's go and see skin to skin. Why do we do it? Now, I'm going to summarize because everybody knows this. It improves newborn stability. A baby skin to skin with the mother has a lower cortisol and will be fine. The ducking down baby in the nursery will have low blood sugar, hypothermia. He's going to start tachypnea and everything because what? Because he's afraid, kind of. So taking care of the hypoglycemia with sugar, it's probably just correcting a little bit the problem. It's not really giving the baby what they need. It should be prevented that by leaving. Anyway, innate behavior, breastfeeding, pain management, we know all of this, so I'm not going to spend too much time, but I underline the cortisol level. Cortisol level, very important. A skin-to-skin baby will have a cortisol level lower for 48 hours. It's going to be a nice baby, calm, not afraid of the eagles and all of these things. It's secure, So this is it. So this is for the newborn. What about the mother? What I say, I'm going to summarize it this way. The birth of the baby is not one birth. It's actually, we teach it's 3 births at the same, sequence. First, the baby is born. Second, when you put the baby on the mother will be born to the baby. It's the birth of the mother. And then there will be the birth of the family when you transfer them and you let them together discover with the partner and everything. That's going to be the birth of the family. That could be delayed a little bit. It's not like so... it's important, but it can be delayed. But right after birth, you have to give some time for the mother to be born to these babies. How does this happen? Apparently, it's through smell. If you touch and smell, you put the baby on her and she starts to, and that's why the little cap is probably optional. We don't recommend it too much right away because they have shown that that's the smell of the amniotic fluid that will actually trigger the love hormone, oxytocin, that will prevent, PPH, and also the prolactin, that's a devotion hormone, and all of these things. That's going to start in the brain of the mother for that baby because of the smell, and she will have a different attitude toward the baby. So I'll show you this. This is the birth of the mother. How do we show this practically? The Swedish people, they have demonstrated that skin-to-skin contact has a long influence, a strong influence on the mother-child relationship. Up to a year now, they say 2 years, they say it's very long. Maternal sensitivity will better calmer baby because the cortisol level of the mother is also lower. For us as healthcare professional, we have less problem with the kids, they're fine, the mother is relaxed, the baby is relaxed, and it's much easier, we don't realize before we try to do this. Mutual reciprocity, meaning that the mother and baby will just speak to each other and they'll interact with each other and be more in contact. And if you remember, touch is very important. It creates this whole repair system into the brain of the baby. So that's why we should probably promote more skin to skin after birth than only immediately. But don't get me wrong. The first hour or two are impossible to replace. If you miss it there, you won't be able to recover. That was shown repetitively. So skin to skin is super important then, and then we promote it after. Okay, so that's now let's go into skin to skin in the OR, because that's a big challenge. I know, I know I've been there, I've done it, and even in my unit, we're still, you know, sometimes debating a little bit, but how to do it. Now, I would like to give you a protocol, a recipe that everybody does, and it's always fine. Unfortunately, it does not exist because quality is universal. This is what I'm going to give you, universal directions or something like this. But safety is how you apply in your unit. So everybody has to get together. When I say everybody, the recovery room nurse, the nurse in charge of the OR. It depends where you do your section. It depends of your physical, the size of the room you're in when you do the section. Some people have no room for much circulation. Some have more. Anyway, so that's why local application needs a dedicated team to do this. So let's go. Inform the patient, especially the father, so that he's going to help you. Prepare the mother gowns to remove it quickly at the birth, not just lift the gown and have the gown at the top, you know, the mother cannot smell and everything like this. Just take it, remove quickly at the time of birth. If the baby is vigorous, don't take it to the resuscitation table in order to avoid sending him into the survival mode, okay? You don't want that. Just give it. And who's going to decide if the baby is vigorous or not? The surgeon, the OBGYN. You know, we do delay cord clamping, so we have enough time to see if the baby is colored, good tone, vigorous. Sometimes it even will start crying a little bit there. So then when you hand it to whoever, it depends on your organization. What we do ourselves is that I turn around and I give it to the respiratory therapist. It has a sterile sheet, you know, and just take the baby and bring it to the mother. And if I tell him, well, no, just make sure he's okay, then you can go to the warming table, but usually no need. Okay, place the baby directly on the mother's skin without drying it out too much. You can dry the back and the head a little bit, but amniotic fluid is very important. The amniotic fluid is the only thing that this baby has smell and taste and touch for 9 months. So don't deprive. So actually we think that the amniotic fluid, when it gets into contact with the mother, and especially the end of the child, the baby, should not be dry too much, so that because they usually smell a little bit this, and they smell amniotic fluid, they smell the mother, oh, this is my mother, this is it, you know, I'm home. And so it keeps them very relaxed because they say, oh, I'm still protected. So only wipe the head and back, spread the baby as much as possible, crosswise over the breast. Little legs, you know, on both sides of the left breast. Depends on how your room is organized, but 2 legs on both sides of a breast here, 2 arms on both sides of the other breast, and you turn the head. I'll show you exactly here. I took these pictures from Sunnybrook skin to skin YouTube video. You should go there if you want any information. This is the way they do, and this is the way we do. And anyway, so that's, you see, you have to turn the head so that it's visible, and make sure that it's not, especially if the mother has very large breasts or very soft, so that it's able to breathe. Okay, but you do this, then you see, so that's the posture. This is well illustrated on both sides of the breast here, both sides of the breast, and we see the little, see, that's our, not our, but their probably respiratory therapists or nurses from the obstetrics or whoever, make sure that It cries a little bit, but not very long, because as soon as it gets back into the amniotic fluid smell and everything, say, oh, okay, I'm home again. And okay, so that's it. So then we continue. Keep the cord long so that the baby does not rest on the clamp. Make sure the baby can still breathe freely. That's what we said. Remove the wet cover and cover the baby with only one dry blanket, not too much, so that you don't overeat the baby. And ask the father. That's where the father is important. You can hold the baby's buttock or thigh. So you have to tell him before, so that you can have a hand on the thigh. They're very happy of doing something. It keeps their mind away from all the what's going on in the room, so they won't pass out, you know. So you give them a job to do, so they do it, and respect the innate sequence of the mother-baby interaction. There's nothing there to intervene, you know, it's gonna all happen naturally. Don't do anything else. Just make sure, probably every once in a while, that the tonus, the color, and the breathing are there, you know. That's the usual, you know, observation of a newborn, and that's it. Transfer the patient on the stretcher in skin-to-skin contact into the recovery room, or if you do your cesarean section on the unit, but then you can go in the room. That's a big advantage of having your own cesarean section room. Hospital that have their own cesarean section room, they have no excuse at all to do that properly. For some other center where it's a different culture, different set of people there could be some training needed. But again, this is so important that we address this epidemic of stress of our mothers and ensure the well-being for long time of our kids, that there is no excuse also not to get together and find solution to this. You see, that's the baby now covered with one blanket, and you see the electrodes of the for the EEG that are not the usual way. You put them higher. Some people even put them at the back, on the back of the shoulder, but that's one way of doing it. And here in the recovery room, okay, again, you know, the little hats are optional, and some people have these kind of baby straps, you know, that there is a zipper. We don't use it. The mother usually, these are twins, but anyway, if people are afraid, you know, you can always at the beginning at least use these things. And now, you know, some people who could say, oh, recovery room, you know, we have other patients there and our nurses are not used to, they don't want to take care of another extra patient, and I don't know about breastfeeding. And solution have to be found by every center, depending on what you, I've seen centers, they train, some nurses are trained, it's not so difficult. And some other centers, they have an obstetrical nurse there for some time at least, to make sure that everything is stable. And some other centers, even if they do their cesarean in another operating theater than the obstetric, they send the patient directly for recovery into a room. With epidural anesthesia, it's possible. I've seen it a lot in smaller hospitals. But anyway, so these are tricks, you know, I bring it. I mean, it's not, there's no magical way. It's your own, you have to find your own solutions for that. But that has to be done. That has to be done. You see, you might say, oh, we don't have the staff in the recovery room. Let's send the baby to the nursery just for that little 1 hour or something. Like, that's so bad. You see, I'm just bringing you this study here saying separation for more than an hour in the first 24-hour period will increase the risk of having to give supplement threefold. See, it's a breaking of the mother and child unit, and you cannot do that without consequences. And here you lose your 4 points of IQ, and then you drive the curve to the left, and then you have all this problem later on in life. Okay, So it should not be an excuse. Should not be an excuse. I just want to show you this. This time is running a little bit, but I just want to show you this very nice studies that they've done. I think it's in Ontario, and they were premature babies, and they recruited the mothers less than 32 weeks pregnant. Yeah, when they delivered, when the 32 weeks premature, and they recruited the mother. They asked for the mother to be the one taking care of the baby. Give 8 hours a day to take care of your own baby at the nursery, and the nurse will just be observing behind. And they did that, and many women, many mothers were willing to do it, and even the father would take over during the weekend sometime. So what happened is that the mother would give the feeding, will just cuddle the baby, change, feed. Of course, all the tubing and everything, the nurses would take care of this, and even the mother would chart, would have a little bit training of charting in the guess what happened? Weight gain was better. Breastfeeding at discharge was way better, of course, because the mother was much. Parental stress, you see, this survival mode went down, okay? And then that's the best thing. You see. Retinopathy, it's called retinopathy of prematurity, which is a severe complication that can get you blind, was 14% when it was the group where the nurses were taking care, nurses and physicians were giving the care, and 0 when it's the mother. Nosocomial infection, 0, and 9%. Why? Every time you manipulate a newborn, he's probably thinking that you're an eagle. And then, cortisol goes up. The only person that is, the only manipulation that is not considered or interpreted as threatening for a newborn, it's the mother manipulation. For strange reason that, maybe we'll discover later, but that's an obvious evaluation of this. So the best person to take care of a newborn is the mother. It's not us. It's not because we have bad intention, we only have good intention, but we have to realize that we're not the mother, okay? So then the baby carrier, why should we use them? I just, there are many studies about this, but in this Italian study now, they were giving free baby carrier to the mothers, and then teach them how to use it and everything. And the intervention patient, they double the breastfeeding at 5 months, just because. And guess what? Their cesarean section rate is just terrible, cesarean section rate. But anyway, even that, they say about 20 or 30% of the patient did not use the free baby carrier because it was hurting their cesarean scar. But then they kept it. They kept in the group, in the intervention group. So they probably would have, without this cesarean section rate, they would have much better results. But anyway, so that's a way of. It is another proof of the touch. Touch, more familiarity, better contact, better development with the newborn, and then breastfeeding and everything else will go better. Okay, so we know that baby carrying, it's an old thing, it's been all the time life, we just forgot about it because many countries, they do it naturally, and actually anthropologists have demonstrated that the social behavior of these kids when they grow up is much more harmonious than ours. You see, you put our kids into the preschool school, and sometimes they even fight, or they have all sorts of behavior, personality. some anthropologists have observed these babies that were carried for the first, let's say, 2 years, 3 years by the mother. It's because this touching and constant massaging of the baby by the mother moving probably helps developing the brain. Same thing for massage. You know, it's a very traditional way of taking care of newborn in many countries of the world. Okay, so we're done. What's the good news? Okay, we don't need to change the type of care we provide. We're good people. We need only to change how we provide the care on the mother, with the mother, or by the mother herself. And there is a way always to find this. It's only a way of changing what we're doing instead. And I predict that in the last 10, 15 years, we will have to review everything we do in nurseries and the way we build our delivery room. And I'm a very strong advocate of LDRP system, where the baby is the mother, they live together, they're together all the time, and there's no nursery. And in Sweden, they are now building intensive care nursery. It's not like all these, thing there. This is the rooms with the mother. And anyway, so protect the mother and baby unit by doing this. We spoke about breastfeeding, tactile stimulation, breastfeeding and massage, baby carrier and maternal proximities. Baby carrier is a form of maternal. We should probably not advocate the strollers, it should be baby carrier instead. You see, you go into these commercial centers and you see all these new mother, the baby is in the stroller and she carries the shopping bag. It should be the shopping bag in the stroller and the baby in the, so that's simple, we just have to do these things, and we can probably change a lot the future of our children. So that's it now. Thank you very much. And you see, this is my poster. This is my birthday today. Take me into your arms.
Lovely. That's lovely. Wow. Lots of wonderful information, Dr. Gagne, and very powerful. I think when you started out talking about putting evidence to practice, it can be challenging to see it happen in practice. But once we know the information, and you've shared the information eloquently today, once we know the information, it's our duty then to make it happen. And like you said, we have a very powerful opportunity, non-recoverable opportunity in that early stages after birth. And so we have an obligation and responsibility to make that happen. So thank you for painting that picture for us, because I think we will always remember many of your comments today. And thank you for sharing with the hospitals who are working very hard at this across Canada. And I'm sure they'll benefit from this. So thank you again.
Thank you. You're welcome.